Welcome to This Explainer. Today, we're diving into one of the most critically dense and frankly vulnerable areas of the human body, the neck. When trauma strikes here, we're looking at a true anatomical crossroads. The respiratory, vascular, and digestive systems, they all tightly converge right here. We're going to look at some gripping frontline data and clinical guidelines to see exactly how medical pros navigate this incredibly intense landscape.
Which brings us to a really intense question. How do you treat an injury when literally millimeters mean the difference between life and death? Think about it. A tiny shift in the trajectory of a knife or the blunt force of a steering wheel, that can be the difference between a harmless graze, severe airway compromise, or massive arterial bleeding. For clinicians dealing with these patients, the margin of error is razor thin.
To understand how these high-stakes scenarios are managed, we're going to follow a clear clinical journey today. First, we'll map the anatomy of the neck. Then, penetrating versus blunt trauma. Third, pre-hospital frontline care. 4, identifying the danger signs. And finally, diagnosis and management.
All right, part 1, the anatomy of the neck.
So, trauma surgeons traditionally view this anatomy by dividing the neck into 3 distinct zones. Zone 1 is down at the base, right, extending from your collarbones up to the cricoid cartilage, which is basically right where your Adam's apple starts. Zone 2 is that middle section, running from the cricoid up to the angle of your jaw. And Zone 3 is the uppermost part, going from the jawline straight up to the base of the skull. Just look at the sheer density of what's packed inside those zones. We're talking about the carotid and vertebral arteries supplying blood to your brain, the jugular veins, your trachea, and your spinal cord. It's crowded in there. Now, statistically, Zone 2 is the most commonly injured area. It's the most exposed, sure, but thankfully it's also the most accessible for a surgeon to operate on. If an injury happens deep down in the chest at Zone 1 or way up at the skull base in Zone 3, controlling that bleeding becomes infinitely more difficult.
Moving on to part 2, penetrating versus blunt trauma.
There's a really stark contrast here based on how the injury actually happens. Penetrating trauma, like a stab wound or gunshot, presents this immediate, highly visible threat. The major risks? Exsanguination, meaning bleeding out rapidly, or direct physical compromise of the airway. But blunt trauma, like hitting a steering wheel in a car crash, that is way more deceptive. The skin might look perfectly intact, but the violent stretching of the neck can actually tear the inner lining of the carotid or vertebral arteries. This creates a hidden clot that can travel up to the brain, causing a delayed ischemic stroke hours or even days later. Part 3, pre-hospital frontline care.
So what does this actually look like out in the real world? Well, a remarkable 7-year study from a UK helicopter emergency medical service reveals the pretty brutal reality paramedics walk into. Over half of these injuries, 51%, are caused by interpersonal violence. Right behind that, 47% are cases of severe self-harm. Only 2% were purely accidental. This really highlights that these injuries often happen in highly chaotic, dangerous, and emotionally charged environments.
Demographically speaking, 83% of the victims were male with an average age of 42. It gives us a very clear snapshot of the population most frequently requiring these massive, life-saving pre-hospital resources.
The crucial question is, what do the medics actually do the second they land? The priority is to stop the bleeding and secure the breathing, and they often have to do this at the exact same time. The data shows that 30% of patients received specialized hemostatic dressings packed with blood-clotting agents. 17% were bleeding so heavily they needed an immediate blood transfusion right there in the dirt. And 15% required pre-hospital emergency anesthesia, which means the flight doctor literally had to chemically paralyze the patient and place a breathing tube at the scene because their airway was collapsing.
And here's where modern data is actively busting some really old medical myths. For decades, paramedics were taught to always put a hard plastic cervical collar on trauma patients to protect the spine. But in the study of penetrating neck injuries, 0% of patients received a collar. None. Why? Well, because unstable spine fractures from stab wounds are incredibly rare. And more importantly, a bulky collar hides the wound, it prevents doctors from seeing expanding hematomas, and it can even increase pressure on a bleeding vessel. So using one can literally increase the risk of death. Crazy, right? That brings us to part 4. Identifying the danger signs. Once the patient actually reaches the emergency room, the trauma team takes over. And they're immediately looking to categorize symptoms into hard signs versus soft signs. If a patient has a hard sign, think severe, uncontrolled bleeding, a rapidly expanding mass of blood under the skin, or bubbling air from a collapsed windpipe, there is absolutely no time to waste. That patient bypasses the scanner and goes straight to the operating room for immediate surgery.
But if the patient only has soft signs, like minor oozing, a hoarse voice, or a wound that's just dangerously close to vital structures, the team has bought enough time. They can take the patient for advanced imaging to see exactly what's happening beneath the surface.
But remember how we mentioned the hidden dangers of blunt trauma earlier? Get this. Between 53 and 79% of patients with blunt damage to their neck vessels have absolutely no symptoms at all when they arrive. 0. That is terrifying. So doctors use something called the modified Denver criteria. It's essentially a screening checklist. If a patient was in a massive car crash and they have any of these signs, like a swooshing sound in their neck, which is called a bruit, or a strange neurological deficit, the doctor knows they have to aggressively screen them for torn blood vessels before a deadly stroke occurs.
Finally, Part 5, Diagnosis and Management.
Historically, if you had a penetrating wound in Zone 2, surgeons would often just cut your neck open to explore it, simply because they didn't have great imaging. But today, the paradigm has completely shifted to a no-zone approach. Thanks to incredibly fast, high-resolution multi-detector CT angiograms, doctors can instantly see these detailed 3D maps of your blood vessels and your airway, regardless of where the skin was actually broken. If that CT scan is clear, many patients get to avoid unnecessary invasive surgery altogether. It's a real game changer.
Now, when an injury is confirmed, the medical management is highly tailored to the specific problem. For penetrating trauma, it might require complex open surgical repair, like literally sewing a shredded carotid artery back together or patching it with a piece of a vein. But for blunt trauma with vessel tearing, the treatment isn't usually surgery at all. It's aggressive antithrombotic therapy. That means giving the patient powerful blood thinners for months to prevent those deadly strokes from forming while the vessel just heals on its own. As you've seen, managing neck trauma is this breathtaking balance of speed, precision, and sometimes just restraint. Sometimes saving a life means a dramatic pre-hospital airway intervention in the dirt. And sometimes it means taking a step back, ditching the cervical collar, and letting advanced imaging lead the way. So I'll leave you with this thought. In a high-stakes clinical environment, where less is often more, how will evolving imaging and field data continue to rewrite the trauma playbook? Thanks for joining me on this explainer. Keep learning and stay curious.